I'm Dr. Holly Zink, Director of Career Development and Training Programs at Frontier's Clinical and Translational Science Institute, and I am pleased to be guest hosting today's episode of Translating Health. I'm especially glad to be here for this conversation with Dr. Anna Cohen, Assistant Director of Molecular Genetics at Children's Mercy and Associate Professor of Pathology at the University of Missouri Kansas City School of Medicine. Dr. Cohen's work focuses on rare diseases, genomic diagnosis, and expanding access to genetic testing, especially for children and families in rural communities. Dr. Cohen, let's start with you sharing a bit about your background and how your role at Children's Mercy, how does that fill your day?
Yes, absolutely. First of all, thank you for having me. It is great to be able to share a little bit about myself and my work with our listeners. So I grew up in Portugal and I always loved biology. And one day we were given some homework about seeing who in our family had certain traits, and that was actually my first introduction to genetics. And at that point, I didn't even know that you could pursue a career in genetics that had such a big impact on healthcare and helping people directly. So that came on later. I left Portugal for my studies. Went through Scotland and Canada and then the US. My last point of training was a fellowship. The American Board of Medical Genetics and Genomics has a fellowship that is specifically for laboratory genetics. So in the realm of using genetic testing for diagnostics or screening purposes. And so I did that. That was a 3-year program, which I did in New York City at Mount Sinai Hospital. And that is what gave me the accreditation to do the work that I currently do. And that actually gave me, the ability to apply for a job here at Children's Mercy and do the job that I do now, which is specifically doing diagnostics for sick children. And I kind of have a dual role for that. I do that in the clinical diagnostics laboratory here, but I also have a role in the research side, which I know we'll talk about more today.
So for listeners who may not be familiar with molecular genetics, how would you explain kind of what your team does in the children's hospital setting?
Yes, absolutely. So just think about how all our cells have DNA. DNA is the code for what our bodies, our cells are doing. It's basically the blueprint of our life. And for each individual. And occasionally there is what we would call like a little typo. There might be a letter that's off, and most of the time that really doesn't have a severe consequence. That's sort of what makes us unique individuals. It makes us, look different, have different traits. Sometimes it might even influence our tastes and dislikes. But occasionally it might disrupt a gene or a protein encoded by a gene that has a really important role in our bodies and in our health. And when that happens, that's when it leads to disease. So the area of molecular genetics is looking for that one typo. What happened there that led to a dysfunction biologically that we're now seeing a health consequence? And we do that by sequencing because our genetic code is a bunch of letters, so we want the sequence of the letters in a specific order. What does it match to? What does it translate to? And we're searching it. So I always like to kind of describe it as playing detective. We're looking through billions and billions of letters and trying to figure out if one of them is different from what we expect, but in a way that has a severe consequence versus just being natural diversity that we have between individuals.
I love that idea of genetics as both kind of a science and a story, and it feels especially relevant when we're talking about rare diseases where families really are searching for an explanation. So I know that you've been working with Genomic Answers for Kids at Children's Mercy. Could you tell us a little bit more about this program?
So the program of Genomic Answers for Kids was created sort of to have a platform on advancing diagnostics, but also collecting data that helps our hospital, but not just our hospital, anyone out there in the world working with rare genetic diseases. So the more we know about the genome across different individuals, the more we're able to pinpoint what's unique versus perhaps just a marker in a subpopulation. So the more data there is, that actually the better the analysis becomes. This program was set up, I think, officially in 2019, although there were steps that happened before that that already built into the program. And we've really been collecting thousands of families and their healthcare information, samples from them that we can then use for sequencing, but not just sequencing, there's also functional work that has happened. The idea was really, how can we, one, improve the diagnostics that is happening, because we know that the technologies that are used day to day are good, but could be better. We're still only reaching about, on average, 35% of a diagnostic rate. And then also, what could we do more, right? You want to get to a diagnosis, but then what's next? And so are there other steps that could happen? And so far, the program has had multiple successes, one of them being the development and troubleshooting of a technology called long-read sequencing, or hi-fi genomes, through a technology that is led forward by Pacific Biosciences. And this was developed on the research side, but is now used clinically. And it's still the only lab in the US that is offering this clinically, right here at Children's Mercy. So
That's amazing.
Absolutely, right? So it's a big success of the research program and how translational that was. Other things that are currently happening are, for example, we have colleagues that we have people working with organoids. These are kind of, imagine growing a little bit of an organ on a petri dish, and you can use that, for example, to test drugs. Instead of testing drugs on a child, you want to test drugs in the lab and know if it's going to work without causing any damage to the child. And they're currently working on this for epilepsy. So epilepsy could have so many drugs or even drug combinations that may work or not work. And if you test these in the lab in a big batch, you're actually saving a lot of possible brain damage on children. So that's another example of where the program is going. And then for me personally, I also have been able to leverage this research program that is well established to look into access to testing, which I know we'll talk about more, but I wanted to plug that in, that the research program is really what gave me the leverage to look into that.
Yeah, it sounds like that program just has tremendous potential. We're excited to see where it's going to go in the future. And as you alluded, I know that during your research at Children's Mercy, you received funding from Frontiers Clinical and Translational Institute as a pilot program for children in rural areas to get testing done at their primary care office. I'd love to learn a little bit about why that's so important to really advancing healthcare and this research for you.
Yes. Again, would love to say thank you to Frontiers for that pilot funding, because it truly led me to get through a lot of troubleshooting, but also get through a lot of important highlights of why increasing access to testing is important, but also challenging, right? If it were easy, it probably would have been done completely by now. So it was great to be hands-on and figure out why it's difficult and how can we start making steps to improve it. So we did have a pilot which ran for a year, and in that year what we really wanted to do is, let's see if we just partner with one clinic in a rural area, how many of these kids actually have a rare disease that we could diagnose easily with the same test that's done clinically, but just doing it through research, which is in this case, faster. And I know that sounds controversial because research is usually not faster, but the reason it was faster is because the waiting list for most kids to get in to Children's Mercy to see a specialist, especially in genetics, can be up to a year. And so if you're just waiting a year to even have your first appointment, where you're going to find out, do I even need testing? Is this the right thing to do? And then you have to go through insurance clearance, and possible sample collection mishaps. That is adding a lot of time to even begin an investigation for these families. And then I'm not even mentioning things like, can the family even come to Children's Mercy, right? The families that live around the area might find it a little easier to come to the hospital, but if you live 4 or 5 hours away, that's an entire day, right? To come for a 1-hour appointment. A lot of parents cannot take an entire day off work, or if their appointment is first thing in the morning, they have to come the night before. Can they afford a place to stay to do this? And we know there's a lot of families that end up not showing up for these referrals that were placed a year ago because they may have forgotten, their situation may have changed, they don't have the ability to come. So what we wanted to do is leverage the fact that we have a research program that knows how to do the testing, knows how to troubleshoot a lot of the sample mailing back and forth. And what we really needed to do is identify providers that felt comfortable engaging in this process. So we were lucky for our pilot. We partnered with a provider who actually did a fellowship training at Children's Mercy and was very familiar with our program already. And so she helped us educate her colleagues at this primary care clinic. And because of that, her colleagues felt confident. Yes, let's do this. Very important is we did ask every provider to introduce this research possibility to their families, but also continue the clinical care as if, there was no research program, because that is really important. You cannot substitute a clinical care route by a research program. But what we were able to show is that we had a diagnostic rate that was what you would expect from an unbiased selection of kids that are suspected of having a rare genetic disease. And for all of them that did have a diagnosis, which was 24%, which is within the range of 25 to 35% that we see in the general population that is tested, we were able to return all of those in less than 4 months, right? Not a single one would even be seen by a specialist in 4 months. And so that is really where the intervention matters. And also, none of these families had to travel. They just went to their regular doctor that they already know, that they already trust, and were able to collect a single sample that was sent to us at no cost to anybody, just to do this test and receive a diagnosis. Now, receiving a diagnosis is just the first step. And that was also where, this pilot kind of highlighted, wow, this is just a drop in the bucket of what these families need, right? You give them a name, a diagnosis that they can attach to what their family's going through, what their child is going through, but they need so much support after that. And unfortunately, we're seeing that a lot of the support that is needed after the diagnosis is also not available in rural areas. So that is sort of the dream future intervention pool, but that is a healthcare system-wide intervention that is needed. It's not something that a small project or a small program can do.
Yeah, I'd love to hear a little more about that. So for families who might be new to this, when a child receives a diagnosis through genomic testing, how does that change? What does that change for the family, for the care team when they receive that diagnosis? What does that really mean?
Yes. So what we're seeing is a diagnosis is often something that's going to help, first of all, the family. So a lot of these families, you'll hear familiar stories of parents that will say, I knew there was something, maybe this doctor kind of brushed it off, or they said, let's wait a little longer. Maybe, they'll develop at their own time, or something's gonna, improve. Let's just put them in therapies and see what happens, right? We've seen that parents usually know that something's is needed, something's different or unique about their child, and they really want answers because that's really where the power lies, is having a name or a piece of paper you can validation. You have a piece of paper that you can bring into whatever extra care you're seeking or support you're seeking, and be like, this is what my child has, this is what my child needs. And that name not only helps advocate for themselves, it also helps them connect to other families. This is what we've heard perhaps being the number one source of support for families caring for children with rare diseases or adults with rare diseases, is being able to connect with others going through the same thing. There are so many resources online, so many Facebook groups we've heard of that are connecting families that get together like once a year. And that just helps having a community of support. And that's, again, it's not gonna, magically cure them. It's not gonna necessarily improve their lives medically, but it does improve their lives in the sense of creating this sense of support.
I can imagine for a family that's living several hours away from a major children's hospital, even just having that validation, that diagnosis in their hand, it can really help make sure that they're getting plugged into those communities. And then the trips that they do have to make into the city or wherever they need to go for that care ends up being more productive because they have that diagnosis in hand.
Yes, and I'm glad you brought that up. A lot of them will have to still come to Children's Mercy because it is such a specialized care center for follow-up, for perhaps extra tests to roll out further complications, or really because their care is so complex that they really need to come here. But ideally, they would come maybe for a day and see everyone they need to see. Is this actually happening all the time? Not quite there yet, but this is the goal, right? To have integrated care that if they know upfront, okay, this child presented perhaps with some developmental delay and not much else, but we know based on our genetic diagnosis, wait, there's other kids that have the same diagnosis that also have an underlying heart condition, right? If they didn't have that knowledge, they wouldn't know that when they come to Children's Mercy, they really should see cardiology and see, is there something going on with their heart that needs monitoring? So that's just an example of, you really are integrating the care, but also perhaps opening the door to care that they didn't know they needed beforehand.
Such a great reminder that access is not just whether the test exists, it's whether that full system really makes it realistic for families to use it. So I'd love to hear a little bit more about your pilot project. How did it go? Have you been able to expand the program? What would it take to really scale this model out more broadly?
Absolutely. So I did mention earlier that the pilot, we considered it successful in the sense that we were able to recruit over 20 families. The diagnostic rate was on par with what was expected. And that we really shortened the time to what we call the time to diagnosis. So from, consenting the individual to the study all the way through returning a diagnosis when there was one to under 4 months. So all of those were successes. The other thing that was a success was understanding that it is feasible to collect these samples from a rural PCP clinic and have those sent over to us. It does require a little bit of extra work from the clinic, but overall, it is very feasible. Now, have we been scaling? Yes, but in a conservative way. So we have expanded. Our original PCP clinic was in Salina, Kansas, and we're still working with them. They're still actually our most active collaborator. And we've expanded to clinics in Newton, Hoisington, and Great Bend. also in Kansas, and we're in conversations to expand to the Missouri side as well, including partnerships with UMKC, since we work with UMKC academically as well. And we also have some potential discussions with KU. So we're really already, trying to plug into these institutions that are used to already catering to rare populations, and just trying to brainstorm. We really also saw that even though it's really easy to help one clinic, once you expand to other clinics, every single clinic is set up differently and has their own needs. There are things that you wouldn't even think of ahead of time as being a potential limitation to participating in a study like this. Like, is there even a FedEx box nearby? Does FedEx come and pick up samples from that area? Sometimes the answer is no, and that automatically makes it unfeasible to send human specimens through delivery that has to be expedited. And so that is where the troubleshooting comes along. Some of these families, we're asking them not to come all the way to Children's Mercy, so not necessarily travel 3-4 hours, but maybe they'd be willing to travel half an hour and go to a satellite clinic. So for example, Children's Mercy has a satellite clinic in Wichita. So some of the families said, oh, we can do that. And that's kind of an in between, not ideal. They still have to go somewhere, but they don't have to go as far, right, to provide a sample. So those are the little things that we've been able to troubleshoot slowly. We wanted to expand much faster and bigger than we have. The limitation has been funding, to be fairly honest. The funding conditions have really shifted in the past year and a half. We were actually really close to receiving funding that then just happened to be discontinued in a lot of the restructuring that happened. And so we've been pivoting and trying to be creative so that we don't have to stop any of these collaborations, but we also can't, actively expand to the extent that we wanted. And the main thing is really catering to each single clinic. What do they need? Because if we're asking too much of the clinics, too much of the providers, or too much of the families, any of these, it's going to not work. It's going to fall apart. It has to be easy. It has to be feasible. It has to be streamlined. Otherwise, it's too much work.
It sounds like a lot had to happen behind the scenes in order to make the testing possible in that local clinic setting. But it sounds like you're getting to the maybe magic formula of really being able to move that forward in the field. I'd love to pivot for a minute for families who are listening who may be facing that kind of long-term diagnostic journey. What would you want them to know about the future of genomic medicine?
Absolutely. So we believe the future is bright. We believe that testing is going to become more and more widespread. So it's not going to be just tests the more extreme cases. I think as we move forward, it's going to be recognized that it's worth testing anyone that has any suspicion of having a genetic diagnosis. And also, I think providers in general, not just in the specialty of genetics, are becoming more familiar with the utility of genetic testing upfront. So not wait until they're very sick or very severe to order testing, but really order the testing at the first sign of there could be something going on here that would benefit from testing. I think that's really where the shift will happen in the next maybe 10 years, that maybe most kids that have any health issues will be tested much sooner and more widespread. I do think that in a way, the COVID epidemic helped a little bit speed up things like telehealth, right? And so that's one of the things that our program has also facilitated, which is communication between providers that are remote with our specialist providers here for advice. Because even though I'm saying we want to test more kids, we want to have this intervention earlier, the testing is also not the right fit for every single child. There are some medical conditions that have a very low yield of having a positive result from genetic testing. And we don't want to just give false hope to every family of saying, hey, do this test, we might find an answer. The yield is still under 40% most of the time, and that's overall. If you look at subcategories of disorders, the yield can be as low as 1% in some categories. So I think it's important to also be upfront of that. And the education of providers all over, it also has a role in that. And then I also want to encourage families to advocate for themselves, right? The parents know best at all times. That's what I've learned from interacting with families directly, because I've been lucky enough to meet families firsthand. And in fact, I myself actually have a rare genetic disorder that I only found out through my training that turned out to be a genetic disorder. So it's kind of a full circle moment. And it really helped myself advocate when I go to my own provider and I'm able to say, this is what I have, this is what I need. And if I didn't do that, I wouldn't receive the same care that I do. So just encouraging families, if you think this is something that you need and your own provider is not helping you, ask them or go see another provider if you can. And there's also always studies that you can reach out to directly.
That earlier genetic diagnosis, as I listen to you talk, really gets at that translational science piece of things, really moving that advanced genomic tool out of this specialized setting and really into the models of care that are reaching more people, especially in the more geographically distant patient populations. I love what you said too, of really helping primary care providers again understand a little bit more of the process. I'm interested, what do you hope rural primary care providers really gain from being a part of this work?
I will say, even in our small efforts so far, I do see that some providers seem to have, more patients that they've nominated to the study that have an actual positive result versus others. And I think they are getting more familiar with which signs might be more suggestive of having a genetic basis to the diagnosis versus not. So there's an education component. I did mention applying for funding that we haven't been successful at yet, but if we ever get this funding that we're still trying to get, there is an education component. We want more upfront education as well, but also continuous education with these providers of here, step one, this is what you look for. But then when we do find a diagnosis or when we don't, discuss why that might be the case based on their clinical features. And then also listen from providers. Is this helpful to them? Because sometimes we're handing back a diagnosis and then they also don't have the prior experience on what to do with that information, right? So as I mentioned, again, this is a very small drop in the bucket of everything that needs to happen for these families.
I know that pilot funding can play such a huge role for early career investigators, especially just turning that idea into a research program. I know that you've really looked at this kind of access problem very interestingly, and you've been able to kind of move forward and find a solution for the research problem that you're looking at. I'm wondering what advice you might give to other early career investigators who are also seeing an access problem in their field, but they're maybe not quite sure where to start.
Wow, that is a fantastic question because I think I'm still trying to fully answer that. I took some small steps into a small intervention, but there's a lot of steps that need to happen. And I think, and I'm saying this to others, but to myself as well, is look at what other groups have done successfully, right? Again, talking about COVID, when COVID happened, those test kits went everywhere. People received care no matter where they lived. It's a feasible thing, but it's only put into action when it's an emergency. Another field that has been getting really good at this, at reaching patients where they are, is in cancer. There's a lot of distribution of resources for cancer care all over geographically that is getting much better. So I think I've had a lot of conversations with people who are integrated in these systems that are many steps ahead, and that have been established for bigger, not bigger projects, but bigger infrastructure, and more supported groups. Talk to the people around you that are more experienced. Get advice. Learn from what didn't work for them. The same way that we've already learned on what didn't work for us and pivoted. If we can talk to more people and we already know what didn't work, why try that again? We can skip some of those attempts and just go straight to other strategies that might work. That's the main advice. But also sometimes starting small really is helpful. You would think that having a 1-year pilot where you partner with a single clinic might not give you a lot of insights. And I was surprised myself by how much I learned with just this one partnership, and how much I continue to learn with the same partnership, because as I mentioned, this clinic is still the most active. We still work with them constantly. We still sometimes have surprises in what is now a new challenge that maybe wasn't a year ago. So just being open and listening and having a lot of conversations.
Yeah, I want to reiterate that because I think listeners may not fully realize how much logistics really matter in research access. The barrier isn't always just scientific, it's geographic, it's operational, it's sometimes a very human problem, right? So it sounds like for you was the kind of pilot project where the lessons learned were just as important as the initial outcomes, and you're really carrying that forward. I would love to hear what gives you the most hope about kind of where rare disease research and genomic medicine is headed. Where are you most hopeful and excited about for the future as we end our podcast today?
I've been in the field of genetics, believe it or not, for 14 years. If we're just talking about going to my PhD and doing everything that I've done since then. So it's crazy that it feels like such a long journey, even though I'm just beginning at the same time. And what I can say that is so exciting is even what I did day one versus what I do now is not even comparable. The scale, what has developed, the technology has advanced so much, but also the costs of doing some of this testing has decreased so much. Nowadays, we can really run not just a standard genome, but what we've developed here, a long read genome, which I didn't even talk about that much, but it's just a technology that basically does what 5 other tests do separately in one go. And it's phenomenal. And that's now coming down to, a few $1,000s, which it's truly unbelievable. When I started my training, this didn't even exist. So I can't even compare the costs change because it didn't even exist. So what I'm hopeful is that, one, the cost is going to become so trivial that this could actually be done on anyone that needs it. I really think that the first step, which is just getting tested, shouldn't even be an issue anymore. Everyone should have access to that. The test should just be run. The issue should really shift toward how do we then help these families get access to the care that they need, and how can this translate into more therapies out there? And we're seeing so many success stories with therapies coming up in the news, and it's so encouraging. There have been, just in the last couple of years, so many new FDA-approved drugs for specific genetic diagnosis, or even just discoveries of new gene therapy delivery models that have helped. So things that, when I started had no cure are actually now having a cure. So if we think about that, what is everything going to look like in 10 years? I am extremely hopeful. I think there's going to be a lot of genetic disorders that are still considered deadly right now that will not be anymore in 10 years. And because of that, I keep working. I think finding the answers and the root cause of these disorders biologically is really what's going to allow the development of all these therapies that is going to save a lot of lives.
Hope and a bright future. It sounds amazing. Well, I want to thank Dr. Anna Cohen so much for joining us today on the Translational Health podcast for Frontiers Clinical and Translational Science Institute. Again, her work focuses on rare diseases, genomic diagnoses, and expanding that access to genomic testing, especially for our children and families in rural communities. So thank you so much, Dr. Cohen. It was wonderful to have you on today.
Absolutely. Thank you.